um, getting 12 lead EKGs with altered mental status patients. And in general, our documentation, at least, is somewhat lacking when it comes to altered level of consciousness patients. So I really wanted to highlight, the altered level of consciousness, protocol, et cetera. So we're literally going to go through it, kind of step by step today. Um, the biggest takeaway from it is going to be, it's really important that you have a broad differential of what this could be, since altered consciousness can manifest from many different diseases. But the important thing is that you've got to go in with that open mind, that something else may be going on with this patient. We've got to figure out as best we can what the reason for their level of consciousness change is. I don't have any disclosures. So the objectives are, we're going to talk about the different types of altered level of consciousness, the approach to the altered patient, what kind of tests and procedures we need to accomplish when we're looking at these folks, and then the treatment for the various different kinds of altered level of consciousness that we're going to talk about. And as part of all this, we're basically going to be going through the protocol step by step, which is SB 201, altered level of consciousness or altered mental status. So the protocol says that this applies to all ages, and the patient then has to have one of the following: a feeling of impending loss of consciousness. So I feel like I'm going to pass out. I felt lightheaded. I felt dizzy. The patient has a decreased level of consciousness of any length, and that can mean, a brief alteration of awareness all the way through grandma's not acting right. Even grandma was staring off into space for 30 seconds and she's now back to normal. That's still a decreased level of consciousness of any length. Or the patient continues to have an altered mental status, which means they're not alert, oriented to person, place, time, and situation. The patient experiences syncope or has a near syncope or pre-syncope event. Again, feeling like I'm going to pass out, actually passing out, regardless of kind of how long the person has passed out for. So our initial approach is, of course, we want to assess their breathing and circulation status. If you have trauma suspected, meaning, a lot of these folks will be standing or upright or something like that, and especially if they completely lose consciousness, will end up on the floor. Do we need to be worried about whether or not they have any kind of other injuries? With the elderly, which is defined in the literature anyway as anybody over age 65, you really need to have a lower threshold for putting them in a cervical collar, depending on the mechanism of injury. So if you have somebody with a ground level fall, who's over age 65, I wouldn't necessarily put them in a collar every single time, but I would definitely take the time to ask them, whether or not they're having neck pain, et cetera. If they are still altered, then yeah, they probably should get a cervical collar. I don't know that I would necessarily be backboarding people that have a ground level fall, simply because it's unlikely that they have any kind of an unstable spinal fracture of the thoracic or lumbar spine. But it's acceptable to assess them, et cetera, and kind of make some determinations on your own. As part of this kind of initial workup, you need to develop a differential diagnosis, figure out why this person had or continues to have this altered, level of consciousness. That way you can figure out, is this something that I can begin to fix here in the field? So we've got a broad differential diagnosis of what can cause this, all the way from anemia to head injury, to pulmonary embolism, through stroke and intracranial hemorrhage. A lot of these conditions, there's not a whole lot definitively that we can do in the field, but we can at least begin to treat their symptoms. And it's important to still keep in mind the various different causes, because it may help guide the way you assess the patient further. So let's talk about anemia first. So with anemia, part of the issue is because you have either too few red blood cells, or you may have enough red blood cells, but the red blood cells are relatively small because they don't have enough hemoglobin. And remember that hemoglobin is what actually transports the oxygen. So if you don't have enough hemoglobin, being circulated, that means that you don't have enough oxygen necessarily being circulated. And so these folks will sometimes begin to develop symptoms of, relative hypoxia. They'll get short of breath even with slight exertion. They'll have an increased heart rate. They may get headaches, dizziness, chest pain, fatigue, low energy, etc. And all that's despite the fact that their pulse ox is likely going to be normal. Remember that a pulse ox is measuring the amount of hemoglobin that is occupied, that is bound. It's not telling you about the raw amount of oxygen that's in the system. So it doesn't necessarily tell you about how much hemoglobin the person has and whether or not that's adequate for the body's needs. It just tells you that the person has bound hemoglobin. Some of these folks are going to have a known history of anemia. They may say, yeah, I have to get transfused every 6 weeks or a couple times a year or whatnot. They may tell you, oh yeah, I just had surgery and I had to get a pint of blood afterwards. Or, yes, I have, heavy periods every month, etc. But this month it seems to be heavier. Really, the biggest thing we can do for them is to treat them supportively. Sometimes these folks will be, kind of soft with their blood pressures. And so a little bit of fluid may help somewhat, especially if they're feeling lightheaded or dizzy. It's also fine for us to give them, if we're suspecting anemia, that if the patient is really, uncomfortable, et cetera, it's okay to put them on a couple liters nasal cannula oxygen, despite the fact that their oxygen level, their pulse ox level may be normal. And all you have to do with that is just document that the reason you did that is because you were suspecting anemia and wanted to help symptomatically treat the patient. And it may help them, briefly feel a little bit better, since they'll get a little extra oxygen circulating in the plasma then. Drugs and alcohol will also cause altered consciousness, but alcohol is rarely the cause of complete unresponsiveness. Will people pass out? Yes. Are they usually arousable after doing so? Yes. You want to assume that anybody that's acting intoxicated, has slurred speech, can't walk, is not making sense, etc. You need to assume that they have a major medical problem first. People that are drunk still have strokes, still have heart attacks, still get hypoglycemic, etc. So make sure that you are still keeping in mind that there's a bunch of other bad things that will present the exact same way. When treating alcohol patients, you want to refer to M411, which is the toxicology protocol. But it's important to make sure that you assess them properly. Some of the time, we're going to see narcotic overdoses where they'll be unresponsive or semi-responsive. So make sure and have that as something in the back of your mind. Obviously, I think all of us are pretty much experts at this point, unfortunately, because of the heroin epidemic. But these folks will have pinpoint pupils, slow respirations, needle tracks, and then you're going to need to treat them with Narcan if their breathing is ineffective. Remember that we use Narcan for breathing. We don't use Narcan for responsiveness or anything like that. So as long as they are breathing adequately, they're maintaining their SATs, their end-tidal CO2 is relatively normal, et cetera, then we probably don't need to give them Narcan. In fact, it's probably better if we don't give them so much Narcan that they, wake up and, begin vomiting everywhere and are uncomfortable and want to refuse. Of course, a lot of other intoxicants will also cause altered consciousness. There are tons of prescription medications that will do this. In addition, there are a lot of supplements, if for lack of a better term, that are completely legal, that you can literally buy on Amazon for 2-day shipping that will make you extremely altered. Anywhere from pills to powders and stuff like that that people will use to try and get high while kind of skirting the edges of the law. Dysrhythmias are one of the worrisome causes of loss of consciousness or altered consciousness. Assess these folks for an abnormal pulse and make sure and get their blood pressure. It may be that you go to take your patient's blood pressure and pulse, and you find that their heart rate is too rapid, or that it's irregular. Sometimes people's initial presentation of atrial fibrillation will be, feeling short of breath or feeling lightheaded or dizzy, etc. And so you find that this person has an irregular pulse, and you ask them, do you have a history of an irregular pulse or an AFib or anything like that? And, some of the time they're going to say, no, my heart rate has always been fine. So you may have just come up with the diagnosis right then and there before you've even done a 12 lead. It's really important to get a 12 lead on anybody that you suspect has a dysrhythmia. And it's really important that you get a 12 lead on anybody that has had any altered level of consciousness. There are a few conditions that we're going to go over, one of which is QTC prolongation. We're going to go over delta waves or Wolff-Parkinson-White syndrome, Brugada syndrome, and then hypertrophic obstructive cardiomyopathy. In general, most of these dysrhythmias are going to be, something that it just requires supportive care. But if you have somebody with VTAC or SVT, et cetera, make sure and refer to the appropriate treatment protocol that's in the system. So let's talk about a prolonged QTC. So with a prolonged QTC, the time between when the QRS complex begins and the T wave ends is called the QT interval, okay? And normally as our heart rate goes up, this time frame has to shorten because we need the ventricle to get ready for the next QRS complex. So normally what happens is this QT interval will begin to shorten. And so the T wave will come closer. However, in some people, either because of drugs or because of hypothermia or an MI, electrolyte problems, or congenital issues, that won't occur. And so as the person's heart rate goes up, increasingly this QRS complex that's going to follow the T wave will begin to get closer and closer and closer and closer and closer to that T wave, until some of the time that QRS is going to hit when you're still in the process of repolarizing the myocardium. What happens then is exactly what happens if you forget to hit the sync button and go to cardiovert somebody. You run the risk of inducing ventricular fibrillation. And that's the problem that will occur with this is typically VFib. So what a QTC is this interval, except it's corrected for heart rate. So that way it's comparing apples to apples, not apples to oranges or apples to pears. A variety of different things will cause this. As I said earlier, drugs can do this. Benadryl and Zofran are two of the drugs that come to mind that are in the back of our drug box. Electrolyte problems, either hypokalemia, hyperkalemia, hypomagnesemia, et cetera, all those will cause problems. But the one that we really, really, really worry about is the congenital one. Congenitally prolonged QTC patients have a fault within their potassium sodium channels, okay? And so as a result, their heart cannot repolarize the way it is supposed to. The reason I harp so much on getting a 12 lead EKG in these altered consciousness patients is because of a case that I had when I was in fellowship. So where I was in fellowship, we all got issued a Tahoe response vehicle that we would use to respond on emergencies. And so we would spend a couple of days a week, literally just bouncing from call to call to call in the region. One day I was out on the road and a call came out for a 12-year-old cardiac arrest. Of course, I started heading that way. EMS arrived on scene. Dad was doing CPR. Story is, kid has a history of pseudo seizures, was walking down the hallway with dad, fell to the floor, seized briefly, and then stopped breathing. Didn't have a pulse, so dad started CPR and called 911. EMS arrives on scene. She's in VFib. They shock several times and give her epi a couple of times. As I'm pulling up on scene, they've just gotten ROSC. So we get her out to the truck. We get her intubated and do a 12 lead EKG on her. Well, her 12 lead EKG comes back with a QTC of 650 milliseconds. Well, anything longer than 500 milliseconds, we start to worry about VFib and torsades. So we had made the diagnosis of what had been going on with this kid for years. So after the fact, we got the rest of the story, which is this kid at about age 9 began having these unexplained passing out episodes. And so went to the hospital I trained at a couple of times, got worked up, even got admitted. At one point got transferred down to University of Michigan so that they could have neurology and more intensive cardiology evaluate her. And they really weren't coming up with anything. There wasn't anything that was pointing them towards what was causing this. So eventually this girl at the age of 9 got labeled as having pseudo seizures, which essentially means she's got a psychiatric illness that's causing her to have seizure-like activity, but it's not really a seizure. In reality, what had happened is nobody had done a 12 lead EKG on this kid. I went back through her chart at the hospital I trained at, and no one had done a 12 lead EKG on her. And this 12 lead EKG, which the hospital gets reimbursed maybe $15 for, never once was done. And a 12 lead EKG would have potentially saved this kid. This kid got super lucky. What I think was happening is every time she passed out prior to the day that I saw her, she had either spontaneously, converted, or in the act of falling had cardioverted herself. And most of the time would regain consciousness and be completely back to normal within 30 seconds. Thank goodness that particular day, Dad happened to be there with her when she fell down. Otherwise, they could have found their daughter dead, in the morning if this had happened while she was asleep. So the kid ended up doing fine. She's actually, I believe, either in college or getting ready to graduate college. Ended up getting pacer defibrillator at age 12 that she'll have to have for the rest of her life, because that's the thing that's going to shock her out of this dysrhythmia. We don't really have any treatment for these folks that have congenital problems. So again, the reason I harp so much on getting 12 lead EKGs on these folks is because literally you could come up with that diagnosis and save this 12-year-old, from certain death. Thank goodness, Dad had been home when this girl ended up arresting. So let's talk about delta waves. So delta waves are one of the things that occurs with Wolff Parkinson White. And just to refresh your memory, well, of course, you're going on an unconscious while we're talking about unconsciousness. So get a 12 lead. 12 lead. So just to restart, delta waves are one of the things that we will see with Wolff Parkinson White syndrome. And with Wolff Parkinson White syndrome, essentially they have what's called an accessory pathway. So they have, for lack of a better analogy, extra wiring. And so instead of the electricity coming from the AV node and traveling out to the ventricles, there's also some electricity that can make its way back up, back towards the AV node. And so that can, of course, begin to cause problems. Because of that, the myocardium depolarizes differently than it does with somebody with a normal heart. So this slurring that you see right here, okay, that slur that you get is what occurs with Wolff Parkinson White syndrome. So it depolarizes weirdly and eventually then gets back to normal depolarization. Okay. So it's that slur, that curving that you get to the QRS complex initially that is the delta wave. The QRS will often be reported as wide because it's measuring from here to here. But if you look, the majority of the QRS complex is actually fairly normal. It's just this initial phase that is oddly slow, and so it gets this slurred response. So that's what a delta wave shows. What'll happen with these folks that have Wolff-Parkinson-White is, unfortunately, that accessory pathway will sometimes lead to them having SVT. However, this SVT is different. If we give them adenosine, we block off the AV node. And so the only thing that is then, essentially carrying the electricity out to the rest of the ventricle is the accessory pathway. And so they can get this extremely rapid SVT following adenosine administration, and sometimes even induce VFib, which can be, of course, very bad. So that's why we worry a lot about doing adenosine without having pads on the patient, is because if we haven't diagnosed them with Wolff-Parkinson-White and we give them adenosine, it can potentially put them into a bad rhythm. Now, ultimately, the treatment, if you get one of these patients that you inadvertently put into an even faster SVT or into VFib, is immediate cardioversion. And that tends to fix it. They don't even necessarily sometimes lose consciousness from it, because you've got to be on top of it that quickly. But that's one of the things we worry about. So these folks will typically, if they're going to have issues with altered consciousness, they're going to present, typically with SVT-like symptoms. All right, Brugada syndrome. This is something that not many people have heard of. It was first described in 1992 by two brothers that were cardiologists. And they described it after taking care of a number of patients that they had that ended up having this disease. So for centuries in Southeast Asia, there has been a disease that, depending on which culture you were in, had various descriptions that translated into things like, death scream, or, nighttime moaning, etc. And what would happen is you would have somebody who was typically middle-aged, typically healthy, and male, who would, for whatever reason, die. And it was kind of an unexplained death. You go in, you take a look at their heart itself during autopsy, and it's a normal heart. It doesn't appear like there's anything wrong with it. These guys were able to determine that it was actually a problem, again, with the electrolyte channels within the heart. So what happens is you have this essentially sloping, this down sloping T wave. So you get this ST elevation with this down sloping T wave. And unfortunately, what happens is similar to what will happen with prolonged QTC syndrome, is sometimes, because the T wave is so big, I mean, just look at how wide that whole process is. If their heart rate goes up, their QRS will occur when they're still depolarizing in the T wave and induce VFib. The incidence is fairly high in Southeast Asia, but you will see it in the general population. The thing that we worry the most about is this type 1. This type 1 is associated with the highest incidence of death. When looking at type 2 and type 3, these will occur in some medical conditions as well, despite having completely normal genetics and completely normal channels. So sometimes you will see these kinds of EKG changes as a result of stress or certain drugs or an MI. The best way to describe the type 2 and type 3 is with what's called the saddleback ST elevation. So if you see there, it almost looks like it's a saddle, that you could ride a saddle in that ST elevation. But you still see, if you go up here to V1, in both of these situations, you still see this odd downsloping ST segment. Okay. So the big thing to watch for is for this one. If you see this weird ST elevation with a down sloping ST segment, that's concerning. The definitive treatment for this is AICD. They need a pacer defibrillator put in their chest to shock them out of the bad rhythm that they're likely going to get into. All right, hypertrophic obstructive cardiomyopathy. Over half of these patients are going to have autosomal dominant transmission, which means you only need one parent with the gene and you're going to get the disease, or at least you've got a 50% chance of getting the disease. Okay. There are multiple different types of hypertrophic obstructive cardiomyopathy. One of the causes will be problems within the proteins of the heart itself. One will be will be in the size of the heart cells. There are also several other infiltrative diseases where fat will get deposited in the septum, which will cause a very similar problem. But what happens is the septum that divides the ventricles will swell, will get super big. Typically it's because of overgrowth. And it will get so big that it now begins to block off the aortic valve. And so now all of a sudden, the blood that normally would get circulated has a much tighter area to flow through. As time goes on, the person will begin to develop a murmur, and they will begin to develop a thin heart wall that will then become somewhat floppy and large. As that happens, the heart itself becomes more predisposed to developing arrhythmias because the muscle tissue is no longer normal. And so these folks will sometimes die of VFib or VTAC. A lot of the time we are able to detect these patients before they have problems, at least here in the United States. Because it has a genetic predisposition, if one of your parents has this, you're likely going to get tested for this. We now have the ability, at least with some of the genes, to simply just do a genetic test to determine whether or not you carry those genes. But it's also relatively straightforward for us to do a 12-lead EKG and other imaging things. The thing for us to look for in the field is these large QRS complexes. You see these huge QRS complexes, and that's an indication of how much tissue there is. It's similar to if you have a small battery, you're going to have small voltage. You have a big battery, you're going to have big voltage. So small heart, you're going to have small QRS complexes. Big heart, you're going to have big QRS complexes. Okay. So whenever you see something like this doesn't necessarily absolutely mean that the person has hypertrophic obstructive cardiomyopathy, but it definitely is something that a patient's going to need to get followed up on. And the way we typically would evaluate them, further when they got to the hospital is we would do obviously our own 12-lead, but we would do a chest x-ray. And these folks will often, when we do a chest x-ray, will have kind of what's called a boot-shaped heart that's enlarged. They also will then go and get an echocardiogram so we can take a look at the actual valves themselves. It'll allow us to see how thick the septum is. And then sometimes they'll even go and get a coronary MRI or cardiac MRI. That allows us to kind of determine what has potentially infiltrated the area. Is this a protein issue, or is this a fat issue, et cetera. In some cases, there are surgical procedures that can be done to help buy this person time. But unfortunately, ultimately, the outcome of this disease is death. The heart becomes too enlarged and too floppy to continue to contract. And so the person dies. The only true life prolonging treatment that will lead to a normal life is a heart transplant. So some of these folks will end up on the heart transplant list, and hopefully some of them will make it. All right, let's talk about some of the electrolyte imbalances. Again, get a 12-lead EKG. Some of the time you're going to have QTC changes when your salts get out of whack. Hypomagnesemia and hypokalemia will both lengthen your QTC. Hypercalcemia will shorten your QTC. Hyperkalemia is probably the biggest one that we need to watch for, especially with the elderly population or with the dialysis patient. These folks will develop an EKG like this, where you have these large peaked T waves that are almost like daggers sticking up. If you notice, you're also going to have this widened QRS. This QRS is super wide, and it looks like it's even potentially wider out here in the inferior leads. Eventually, without treatment, this condition progresses to sine wave. And you can kind of see up here in lead 1, you kind of already see that this is a sine wave, okay? Up, down, up, down, up, down. You really can't determine what's a QRS complex and what's a T wave. So this person here is in a very dangerous spot and needs immediate treatment for it. And we do have a protocol for hyperkalemia treatment. It involves us giving them IV fluids, sodium bicarb, and albuterol inhalers. And the reason we use the albuterol is because it also helps drive some of the potassium back into the cells. The definitive treatment, though, is to get the potassium level to go back down, either through getting rid of the potassium or dialyzing the potassium out. The other thing that needs to occur is calcium. Calcium will help shorten that QTC, make these waves begin to appear closer to normal, and it stabilizes the cell membranes of the heart tissue. So make sure and give them calcium if that's something that you have access to. Head injuries can also cause this. We probably have all dealt with the person who has, bumped their head, has a concussion, is not acting right, is confused, maybe having repetitive questioning, etc. All these things, point towards altered consciousness. So refer to S501, P613, and/or symptom-based 210. Those will all tell you how to assess a head injury and what treatments you need to do. Hypertension is also a cause of change in mental status. We typically only really get concerned when somebody has significant hypertension, which is a systolic blood pressure of over 200, along with symptoms. And the symptoms that folks will typically get is a headache, confusion, vomiting, blurred vision, chest pain, and shortness of breath. So one of the things that's different with hypertension for us is that generally we cause more harm than we provide benefit if we treat this in the field. And in fact, there's even some literature that says that we shouldn't treat it aggressively in the emergency department either. What we should do is we should treat their symptoms at the same time we're assessing them for possible stroke. So if somebody is having a headache, give them pain medicine. If somebody is vomiting, give them Zofran. If somebody is having, shortness of breath, assess them for that. But in general, we don't tend to treat this with the kinds of medications that we carry in the field. If somebody comes into the hospital with a hypertensive urgency or a hypertensive emergency, where they have symptoms associated with their high blood pressures, even then, we are only going to lower their blood pressure some. The brain is extremely good at regulating its own blood supply. And so when someone is significantly hypertensive like this, the muscles within the blood vessels that control the brain are going to spasm down some to reduce the amount of blood that's getting up to the brain. Since you're under high pressure, it doesn't require the same diameter to get the same blood flow. But what happens is if we suddenly drop this person's blood pressure, back to normal very quickly, the muscles don't have a chance to begin to relax. And so as a result, you begin to cut off their blood flow. Their muscles will be spasmed down, restricting the blood flow for that given blood pressure. So we typically, our goal when we're treating somebody like this in the hospital is to lower their blood pressure by no more than 20 to 25% over the first 24 hours. And to do that safely, we will typically use ultra short acting medications, stuff that you have to have them on a drip with. And the things that are typically used for that are nitroglycerin as a drip. We sometimes will use a beta blocker called esmolol, and sometimes a calcium channel blocker called nicardipine. And the reason we choose these drugs is because they're essentially on and off. The moment you shut off the drug, very quickly it's metabolized out of your system, and it's out of your system in a matter of a couple of minutes. So we're not having to chase our tails after having given somebody something longer acting. We're not having to try and get their blood pressure to come back up because we gave them too much of this long acting medication. Hyperglycemia can cause this. We've all, I'm sure, taken care of that DKA patient that's altered and confused and combative sometimes. These folks will have a glucose of over 400, or their meter will read just simply high. The long and short of it is there are two protocols that deal with this, M406 and P608. Adults, we typically want you to give between 500 and 1,000 milliliters IV bolus if there's no sign of pulmonary edema. For pediatric patients, you're going to give them 20 milliliters per kilogram to a max of 1 liter IV bolus, again, if there's no evidence of any pulmonary edema. Ultimately, we're going to get this person insulin, but we've got to get their lab work back before we can safely give them insulin. Hypoglycemia will also cause altered mental status. Again, we've all taken care of them. Their glucose level is less than 70, or their glucometer reads low. If your history is pointing you towards a suspicion that this patient is hypoglycemic, but you can't measure the level, say your glucometer is broken or whatnot, it is far better for you to go ahead and treat them as if they're hypoglycemic and just document the problem that you had. Give them oral glucose, give them glucagon, give them D10, give them D50. The protocol that treats this stuff is M406 and P608. In general, I recommend using D10 if you're going to treat someone with dextrose at all. And the reason for that is because it's far less complicated to administer. You don't have to worry about your line quite as much, because if the D10 gets out, it usually is not enough to cause any tissue necrosis like D50 is. They tend not to get super hyperglycemic after administration of D10 like they do with D50. And in addition, they don't get that rebound hypoglycemia. I'm sure we have all probably seen at some point where we give them D50, their blood sugar comes up initially, but then it begins to plummet again. And part of that is because we gave them so much sugar that their pancreas kind of woke up and went, wow, that's a lot of sugar. I better put out some insulin. And so puts out some insulin that then causes them to drop again. D10 tends to cause that significantly less. The dose of D10 is the same regardless of your age. It's 1 to 2 milliliters per kilogram given as an IV bolus of D10. Hypoxia will also cause this. So anybody who's got a pulse ox that's less than 95%, we want to make sure that we administer oxygen to them. Remember that there are other things that will cause you to have a falsely elevated pulse ox, like carbon monoxide poisoning. So if you have someone that you're suspecting has carbon monoxide poisoning, you need to get them on a non-rebreather so that you can begin to wash out that carbon monoxide. And this is despite them having a completely normal pulse ox. Only thing I ask is that you document. Document. This is why I thought this patient was hypoxic. This is why I didn't think that their pulse ox was reliable. And so I put them on oxygen. Infections will also cause mental status changes. The one that we worry about probably the most is meningitis. One, if untreated, it has a high mortality rate. And two, depending on the pathogen, it may be highly transmissible. So it's important whenever we have one of these folks that we try and get as much history as we can, either from them or from whoever's on scene with them. It may be that for a couple of days they've been complaining of a headache and some neck stiffness and having a fever, etc. If we have somebody at the hospital that we're concerned has meningitis, the standard of care is for us to do a lumbar puncture on them. That way we can determine whether or not this person truly does have meningitis. And if it is meningitis, what kind of meningitis? Is it a virus or is it one of the bacteria? There's only a couple bacteria that we get worried about, that we get super concerned about with needing to give medication to the people exposed to the person. If for some reason you transport in somebody that has one of those pathogens when we do our workup at the hospital, our infection control team at the hospital is going to hunt you down. They are going to find you, and they're going to figure out what pharmacy you use so we can get you your antibiotics to help keep you from getting meningitis. However, it's more common, especially with the number of nursing homes that we have, for somebody to be altered from a urinary tract infection or from pneumonia. So don't forget that you also need to worry about the most common, not necessarily the most devastating. Make sure to assess them for fever and treat that per M421, which for adults is 650 to 1,000 milligrams of acetaminophen, and for kids is 15 milligrams per kilogram oral solution. Assess them for sepsis and treat it per M419. Myocardial ischemia will also cause this. We probably have all taken care of a STEMI patient that is altered because they're so focused on their pain, or they're so focused on their breathing, or their blood pressure is low, etc. But you need to have this in your differential diagnosis whenever you are taking care of an altered patient. Make sure again and obtain that 12 lead as soon as you possibly can. Treat it per the acute coronary syndrome protocol, which is M400. Keep in mind, there are groups that will have atypical presentations, like the elderly, females, diabetics, chronically hypertensive patients. I actually had a 30-year-old, long story short, about a week, 10 days ago, that ended up actually having a non-ST elevation MI. Came in after cracking his neck at work. Otherwise healthy guy, smoker. Mom had early coronary disease when she was in her 40s. Came in, my neck hurts. It hurts worse whenever I move it, etc. Oh, and by the way, I got a little bit short of breath when I walked into the hospital today. But otherwise, I have no chest pain. I have no shortness of breath. Well, luckily, my PA picked up on the shortness of breath and decided to do some blood work. And lo and behold, the guy had an elevated troponin, which indicates that his heart was having some damage occur to it. So long story short, we put him on blood thinners, get him transferred over to Anderson, so that way the interventional cardiology guys could take a look at him. And he ended up getting a stent put in. And his only presenting symptom really was neck pain after popping it at work, and a little bit of shortness of breath. So you've got to have a fairly low threshold for doing 12 lead EKGs on patients, because every now and then it's going to come back and really hurt, or really help you. For us to determine whether or not somebody's having a PE in the field, but at the same time, it's also difficult for us at the hospital, frankly. It's important to determine whether or not the person has a DVT, or if they've got a previous history of DVT or PE. Really, the only thing we can do is treat them supportively. If they're hypoxic, but of course, be coming in through the venous side. And part of our issue is all of our tissue in the lung is potentially plugged up with a blood clot. And so if we flood them with tons of fluid on the venous side, that's a lot more work that right side of the heart has to do to actually push the blood through the lungs. And so it will cause all kinds of problems. So psychiatric illness will also sometimes cause altered mental status. I would really caution you, though, to always treat these folks the same way that you would treat somebody who appears intoxicated. You've got to rule out medical causes first. Even schizophrenics get hypoglycemic, etc. So make sure and rule out medical causes first. The psychiatric causes like anxiety and things like that really should be at the bottom of your priorities. There are so many really, really big and bad things that will present with the exact same cluster of symptoms that anxiety produces, that you are more likely to miss something medical if you just simply label things as anxiety. I always tell patients at the hospital that anxiety isn't something that we can test for. There isn't a blood level that we can draw that says, yep, this person is actually truly anxious. Whoever invents a test like that is going to be a billionaire overnight. But in general, it's what we call a diagnosis of exclusion. You've got to rule out a bunch of really big bad things like infections and PE and MI and other things like that, that will have the same cluster of symptoms as somebody who's just anxious. Obviously, if the person is becoming aggressive, you want to treat them with M407, which will allow you to hopefully gain better control over the scene. Seizures will also cause altered consciousness. We've all taken care of that post-ictal patient that's either confused or confused and combative. These folks you need to treat per M410, which is the seizure protocol. Remember that the initial way of treating somebody who is actively seizing is with intramuscular midazolam. And that's for kids as well. For adults, it's 10 milligrams IM. For medium-sized kids, it's 5 milligrams IM. And for little kids, it's weight-based. So make sure and refer to your pediatric drug dosing chart. And that spells out exactly how much the kids are supposed to get. Make sure as part of this, though, you're still getting a 12 lead, you're still doing, blood sugar, etc. There are many different kinds of shock that will also present with altered consciousness, because whenever somebody gets hypotensive, that begins to, of course, affect perfusion to their brain, which means the brain may not be working completely appropriately. So identify why the patient's in shock and treat it per that protocol. So if they're in a hemorrhagic or a hypovolemic shock, it's going to be S500 or P614. If they're in a cardiogenic shock, that's going to be M401. Anaphylactic shock, which is M409 and P609, and then septic, which is M419. For all of these, unless it's cardiogenic, generally the initial treatment will be fluids. So unless it's cardiogenic shock, in which case that can sometimes make it worse. Stroke and intracranial hemorrhage will also cause this. And what's difficult about these folks is that the patient may not have an altered level of consciousness. I have taken care of numerous patients that get brought in for altered consciousness or confusion, when in reality, after you start actually assessing the patient, they're completely awake and alert and actually have had a stroke that affected their language processing centers. And so I've had families bring their loved one into the hospital saying, grandma's just been talking out of her head for the last couple of days. She's not making any sense. It's mostly gibberish that's coming out, et cetera. And you start assessing the patient, and you can tell the patient understands every single thing that you're saying to them. But when you ask them to answer a question, it'll be gobbledygook that comes out, or it'll be completely inappropriate words that will come out. And the patient will typically get visibly frustrated because they think that they are saying the right thing. However, they can tell that they're not saying the right thing. We just don't speak their language anymore. The same thing will happen sometimes if somebody has what's called a receptive aphasia, which means the patient can no longer understand language. That part of the brain has been damaged. And so as a result, they'll be able to talk to us, but anything we say to them is Greek, and they will never once speak Greek in their life. So that's equally frustrating. Sometimes with those patients, you have to actually communicate kind of like charades. because depending on how bad that area was affected, you may not even be able to write things down and have them recognize it. It's important to treat these, according to the stroke protocol, which is M414. Make sure you perform a Cincinnati stroke scale and a CSTAT on these folks to help determine where they need to go. Toxins. If you haven't looked at the toxins protocol here lately, I would highly encourage you to do it. It is way too in-depth for me to try and get done as part of one lecture that's already about something else. So please go back in, take a look at it, etc. Because there's tons of different drugs, diseases, etc. that are in there that have specific treatments outlined for them. So to wrap things up, whenever you take care of somebody with altered level of consciousness or confusion or dizziness or lightheadedness or whatever you want to call it, get a 12 lead, even on refusals. Yes, that refusal too. What? They don't want a 12 lead? Okay, document it. Because if you show up on one of these folks and don't get a 12 lead, as you probably have discovered since I've been replying to a lot of these with, hey, where's the 12 lead? You're probably going to get a, hey, where's the 12 lead from me. If you just explain, hey, look, we were in the middle of Kroger, patient didn't want to come out to the truck, and I'm not about to expose somebody in the middle of Kroger. Okay, I get it. Or patient did not want a 12 lead, did not want vitals, whatever. Okay, I get it. We can't force people to to do stuff. But please, please, please try and get a 12 lead whenever you can. All right. So I know that I'm only dealing with one station at this point, but any questions?